Thank you so much for the introduction, and it's a true pleasure to be back in Brazil and to discuss with you a potential pathway to improve long-term outcomes after transplantation. And improving long-term outcomes is, I think, the biggest clinical and research challenge we are facing at the current time. I will address three aspects. First of all, I will position solid organ transplantation as a chronic condition. I will then highlight a new model of care. I'm asked to talk louder, so I try to do that. So to address a potential new model of care provision in transplantation based on the chronic illness management, and then presenting first evidence on the effectiveness of this model in transplantation. Transplantation is a chronic condition. Transplantation is a chronic condition because patients move from one chronic illness state before transplantation, together with potentially a number of comorbidities, to post-transplant time, where most of the patients within the first year already develop new comorbidities based on their side effects of the immunosuppressive drugs. Now, in order to appreciate the development of chronic disease, we have to really see it on a disease continuum. The end-stage organ disease doesn't occur from one moment to the other. We have patients who are at low risk, then they have risk factors, have early signs of their disease, develop symptoms, have the disease, are then post-onset, and it's only then that transplantation comes. Multiple comorbidities, as already said, before transplantation and developing after transplantation, make that patients are dependent of a lifelong medical treatment, continuity of care, and have a huge responsibility in daily life to make sure that the treatment regimen is implemented. It's a non-sexy part of transplantation. It is about health behaviors. It is about healthy eating, regular physical exercise, taking medications. It is also about issues that are linked to psychosocial aspects of care. And outcomes after transplantation, we have strong evidence that not only health behaviors are independent risk factors for poor long-term outcome, but also depression drives mortality not only in heart transplantation, but also in other solid organ transplant recipients. So if we look at survival curves of transplantation, and I give here the example of heart transplantation, but we could also look at liver or kidney transplantation because they are quite similar. And we see the survival curves by transplant era. And we look at the survival curves and we think we are happy. But the happiness is primarily in the first year post-transplant because this is where improvement has been made. If you look in the long term, we see that the survival curves have remained quite similar. And the real challenge is, how can we improve this long-term survival? Looking now from another perspective, which is attrition of organs, functioning organs over time, what you see here is by time post-transplant. Yellow line, 0 till 1 year. Then we have red from 1 till 3 years. Green 3 to 5 years, and then 5 to 10 years is purple. What we see here for the different organ transplants, again from the period of 1989 till 2009, we see that the attrition has decreased really in the first year post-transplant. However, attrition afterwards has remained pretty the same in the different solid organ transplants. So we see remarkable survival patterns But at the same time, as already mentioned, we have the comorbidities that develop under immunosuppression. We also have comorbidities that develop driven by specific risk factors, and we see that they are higher in solid organ transplantation compared to the general population. It's very clear that the burden of comorbidities is significant, and this burden of comorbidities is driven to a large extent by health behaviors, as well, of course, as other factors related to the immunosuppressive regimen. So our goal is to look at new pathways, to look at how can we improve long-term outcome after transplantation. And I would like to discuss with you a specific systematic approach, which is not anymore looking at molecules of medications, new surgical techniques, but much more a model of care which allows us to tackle those risk factors that drive poor outcome in the long term after transplantation. And this is called the chronic illness management model. Now, just taking a step back, if we look how our patients traditionally are being treated in transplantation, we can characterize this by an acute care-driven paradigm. And this is illustrated by a radar screen, and in the middle of the radar screen is not a patient, but a healthcare provider. Patient has a problem, he comes into the radar screen, is treated by the principle, find the problem and fix it, patient is discharged, and then disappears from the radar screen again. Now, what we know from a lot of scientific evidence is that patients with chronic conditions, which is a huge population, it's the healthcare challenge of the 21st century, are not served with an acute care-driven model, because psychosocial and behavioral aspects of disease that drive poor outcome are not addressed, prevention is mostly disregarded, continuity of care and proactive care, which is so important in chronically ill patients, is not integrated, and follow-up care is not always guaranteed. So there the question will be, what will we do? Will we continue to kind of offer a care system which is not fitted to the needs of the population? Or will we look around and learn from other chronically ill patient populations and see if we can find another way? In other words, the current system of care is not really functioning. Trying harder, like hamsters in their wheel, will not really work, so it will be changing systems of care. And if we talk changing system of care, this is not about kind of doing a small change. This is a paradigmatic change. And I would like just to make the analogy with making cars greener. This is not making cars greener. And this is also not making cars greener. It's a new concept of making cars. So in other words, you have to think system, going away from the molecular level, from just the relationship between the healthcare provider and the patients, to looking at how do we organize our care, how can we re-engineer our care system in a way that addresses the needs of our patient population, our transplant patients, which per definition are chronically ill. So the goal is, and this is really the direction, improved functional and clinical outcomes. We don't do this because we like it for our own ego, or we like it because we would get nice publications. We do it because we would like to have improved outcomes. The first element in such a system, and there are several other elements that I will immediately also introduce, is that you have to have an informed active patient. Patients with chronic disease, between 80 and 99% of their care take place in daily life. There's no healthcare provider around. If these patients do not have in their backpack skills, knowledge, and motivation to follow up the care regimen, the best treatment will fail. You also have to have a proactive practice team. And a proactive practice team means that you have a team that is working together towards these improved goals has the skills in order to do, for instance, behavioral assessments and behavioral interventions, to invest in quality improvement, and there needs to be a proactive interaction between the patients and the team. Then there is the system, and this system is not a building, it's not just one clinic, it is a whole concept of how all the care providers are connected with each other. And there are several aspects that characterize a system of chronic illness care, which, by the way, has been implemented in diabetes, in heart failure, and might also have opportunities for transplantation. The first is, yes, supporting this patient that he's ready to go home and to take care of him or herself. We kind of rethink the way care is provided in the sense that we look at the different team members and define who can contribute to which outcome and integrate it in a care path. Decision support, evidence is out there, evidence is not used. It takes about 17 years from a randomized controlled trial between implementation. Decision support can help in the sense that embedded in information systems, care providers can have support to and access to the latest evidence in making their treatment decisions. And clinical information systems is not only for the decision support, but is very much also there to provide continuity of care. You need to have a very good IT system with the electronic patient file in order to link not only the transplant clinicians, but also the family caregiver, the family physician, perhaps the nursing home, in order to provide all information. And this kind of set of care is integrated in, of course, links to the community. Communities provide walking groups, support groups. There is meals on wheels for patients who can't cook themselves. And this can also be integrated. Now, this sounds all very abstract, and I will come much more to detail once I address the example with the evidence, with the outcome evidence. Efficacy of the chronic care model has been shown in a number of controlled trials in a variety of settings, pathologies, and target groups. And examples are, for instance, in patients who have diabetes in underserved communities, where there was a lower hemoglobin A1C, a lower non-high density lipoprotein cholesterol, and a higher frequency of patients self-monitoring themselves. Another example is in patients with severe chronic mental illness. Chronic care model resulted in less proportion of the time that patients lived with symptoms. They had a higher social role function, better mental quality of life, and a greater treatment satisfaction. And then looking at cancer and comorbid depression in Hispanic women, there was less depression and better emotional well-being. We know very, very little about practice patterns related to chronic illness in transplantation, and we therefore launched a large international study on 4 continents, 10 countries, and 40 heart transplant centers, in which we look at specific factors within transplant care which are linked to chronic illness management. The goal is to better understand where we are and also to benchmark different countries and centers among each other. We also collect a set of information on healthcare behaviors of patients. Brazil is part of this study, and these are the hospitals which are currently participating. The study is coordinated in Brazil by UNIFESP and the Albert Einstein Hospital in Sao Paulo, and Samira Salso de Almeida, who is sitting here in front, is the coordinator of this study. We hope by the autumn 2014, and for Brazil, probably in 2016, to have the first results. But now, let's go to this chronic illness care model abstract concept, which has been tested out in a transplant care center in Ottawa, in Canada. This was a paper which was published this year in Clinical Transplantation, was rejected by the American Journal of Transplantation by Transplantation because I don't think they understood how important this study was for transplantation. It used a pre-post design with a perfectly done statistical analysis, in the sense that they used propensity score match controls. So as said, it were Canadian adult renal transplant patients who were more than 6 months post-transplant. Initially, they had in the pre-phase 119 controls, and once they had implemented the system change, they had 61 intervention patients they followed up. Out of these two groups, they could have 40 matched patients, which they compared in their analyses. The intervention was built completely on the chronic illness care model, and it consisted of focus on self-management, shared decision-making, and healthcare delivery and systems reorganization. Outcomes, they looked for primary outcomes at the attainment of 7 of 9 targets as per published guidelines, and secondary outcomes were clinical outcomes and health resource utilization. Now, what is this group of transplant clinicians who completely kind of changed their practice do? I mean, it's not high rocking science. All these elements will probably be familiar to you. Intervention took place from 2006 to 2009, and they had evidence-based standards in the form of medical directives to guide and outline the scope of practice for advanced practice nurses that joined the team. So this was an important aspect of this intervention. They had somebody who joined the team who kind of took care of aspects which were underserved before to do with behavioral and psychosocial issues. They also had a policy that outlined clearly the expectations and role of each team member. So it was not tacit knowledge, but it was written out. There was a collaborative practice environment supported by weekly interprofessional patient rounds, and this is easily said, a collaborative practice environment, much more difficult to live because it means that every voice on the team is really taken into consideration. As said, an advanced practice nurse was added to the team, and there was, she and the nephrologist did a review of each case which presented at the day of the patient clinic visit. And there was a very structured approach to monitor and follow up clinic visits based on the mentioned practice guidelines for chronic kidney disease and renal transplant management, and in total, about 40 minutes was spent per patient. Without going into detail, I just would like to also mention that in this transplant program, they implemented a set of interventions in order to enhance adherence with health behaviors. And for instance, each time the patient came, they monitored adherence as the 6th parameter. They emphasized each time again how important it was, and they implemented interventions when needed. Looking at the outcomes, results showed that of the 11 process measures that they assessed, that 7 of the 11 improved. And you can see here which kind of process measures were improved, partly in view of being prescribed specific medications and monitoring specific aspects of the treatment. Looking at clinical targets reached, what this program showed was that 5 of 9 clinical targets improved significantly in the intervention group. Again, the red star shows you where improvement took place. Primary outcomes, so overall, there was 68% of the intervention group. There was adherence to the guidelines compared to 10% in the control group. But interestingly, and perhaps most importantly, looking at the secondary outcomes, this model of care, this re-engineering operation, resulted in less emergency room visits and less hospital admissions, which I think might be of great interest to health policy makers. So coming to conclusion, what I tried to do is to show you a potential pathway to improve long-term outcomes in transplantation. It is based on a systematic approach to care, a systematic approach which is already known in diabetes, COPD, heart failure, has so far not yet been tested in transplantation, but the drivers for poor outcomes in the long term are drivers linked with comorbidities, non-sexy drivers, which only can be targeted if patients are involved in care and do better at home, and if each time patients come to the hospital, these elements are assessed. So it's about a paradigmatic shift towards chronic illness care in transplant patients to tackle drivers for poor outcomes. And I think the work of Ottawa shows that this is not just something which is far out there. It is feasible, it takes leadership in the transplant programs, it takes a whole team to be willing to invest, but I think the Ottawa data shows that there is really a possibility to improve process, clinical outcomes, and healthcare utilization parameters in renal transplant recipients. And I hope that this data inspires some of you to also go into that direction. Thank you so much for your attention.
Bom, acho que o maior convite dessa palestra é uma reflexão de nós, enquanto transplantadores, equipe multidisciplinar, de como que a gente está cuidando dos nossos pacientes no follow-up do pós-transplante. O que a gente tem feito efetivamente para minimizar as complicações, as comorbidades dos pacientes, porque a gente sabe que isso tem um impacto direto na sobrevida do paciente, do enxerto e na qualidade de vida dos pacientes também. Então, acho que essa é uma boa reflexão e a gente vai abrir para perguntas agora.
Bom, Sabine, obrigada pela sua aula. Acho que esse é o que você falou, na verdade, é uma necessidade, uma impressão que a gente tem quando você se preocupa em tratar bem o seu paciente no pós-transplante. Eu gostaria só que você comentasse, a gente tem hoje no Brasil um sistema que você conhece um pouco e que é dispensado de forma gratuita tanto a assistência, o acompanhamento como a medicação para esse paciente. Mas nós não temos previsto no nosso sistema ainda, né, o acompanhamento por outros profissionais que não sejam os nefrologistas e os cirurgiões, né. A nossa lei, ela prevê apenas que para ter uma equipe de transplante, ela precisa ter só os clínicos, médicos e os cirurgiões envolvidos na cirurgia do transplante. Então, eu gostaria de que você comentasse e fizesse algumas sugestões de como a gente pode, dentro do nosso sistema, caminhar para esse modelo de doença crônica.
If you look in countries, I mean, where at the policy level, such as Basque in Spain, Rwanda, the Netherlands, they have taken an initiative from the highest level to give incentives to develop this kind of a chronic care model, and not only for transplantation, based on the evidence that is currently available. It is quite difficult for, let's say, the individual transplant clinician to take this initiative. I strongly believe, and I also have lived it myself in the heart transplant program at University of Leuven, where the director of the heart transplant program took the decision and took the leadership in order to make it happen. And in Ottawa, it's exactly the same. It's a matter of vision, of having initially a number of resources available, perhaps from other sources, in order to try it out. And then, of course, like each other of these changes, implementation science is absolutely needed to evaluate it. But let's say that there is so much interest for this improvement of long-term outcomes. If you know that the system of care that is currently prevailing is a system of care that doesn't optimally address the needs of patients, if you know that nurses are much more cheaper, and if well-trained can take over a lot in the follow-up of patients, for every rational, I think, transplant director or health policy maker, it's certainly a path that needs to be further explored.
Mais alguma pergunta? Existe algum centro de transplante cardíaco aqui na sala, nesse momento? Porque o Bright Study, na realidade, a gente vai iniciar a coleta de dados por volta de janeiro e fevereiro. Então, se algum centro de transplante cardíaco se interessar, ainda é possível entrar nesse projeto de pesquisa. Então, se ninguém tem mais nenhuma pergunta, eu gostaria de agradecer à professora Sabina pela excelente apresentação. Obrigada a todos.